So we are now live and recording. So we're going to give it a couple of minutes for everyone to start joining. So this is MQ's Open Mind. My name's Bryony. I'm the head of marketing here at MQ, and I'm hosting today. So thanks for joining everyone who's already logged on. I can see quite a few people have joined us already. So I'm going to give it a couple of minutes just to let everybody join and get settled in, and then we'll get going. In the meantime, feel free to introduce yourself in the chat. We'd love to see who is online and watching us already today. Also, if you wanted to tweet about the webinar today, you can use the hashtag MQOpenMinds. And feel free to tag us on social media as well. We're across all channels at MQ Mental Health. Oh, we've got some international viewers online. So hello to everyone who's joining us already. I'm just waiting for the numbers to settle, and then we'll be starting. So in the chats, we've got Juan Carlos from Argentina. Thanks for joining us from Argentina. We've got Iris from Barcelona. Sophie from Denmark. We've got a truly international audience today. Some from Massachusetts, fantastic, and Helen from London. So people from all over the place joining us already. Thank you very much. We're just going to give it another minute or so for a few more people to join. So as I said, if you wanted to introduce yourself in the chat, please do. If you want to tweet about this today or post anything about the webinar online, the hashtag is MQOpenMinds. Please use the Q&A function as well if you want to ask a question to any of our panelists today. We're going to be doing questions from the audience at the end of today's webinar. Okay, so I think our numbers have kind of settled down a little bit. We've got a few people here. Hello to Claire from the Naked Frank Theatre. Oh, we've got an Australian living in London who's joined us as well. Hi, Andre. And from a very wet Cornwall. Yeah, it's quite wet here in London where I am as well at the moment. So I think we're going to get going. So welcome to MQ Open Minds. Thank you for joining us. Today we're discussing how mental health research can help address inequalities. So in less than 2 weeks, on the 10th of October, World Mental Health Day is taking place. And the theme this year is mental health in an unequal world. But what does research have? What role does research have in addressing the inequalities that are in mental health? Many people face disadvantages caused by inequalities, and that can significantly impact their mental health, whether it's growing up in financial insecurity, whether it's maltreatment from having a disability, or if it's growing up as a person of colour in what is a structurally racist society. Addressing these inequalities can play a really large role in overcoming mental health problems for millions of people across the globe. So today, to discuss this, I'm absolutely delighted to be joined by Andrea Corbett, who is an MQ ambassador and coach, by Dr. Gareth Griffith, who is a senior research associate at the University of Bristol, and by Dr. Praveetha Vitale, the associate professor at the University College London. So I'd like to have each of you introduce yourselves. So Andrea, why don't you go first?
And thank you very much, Rani. So my name's Andrea Corbett, as mentioned. I am an MQ Mental Health ambassador. I'm also what I call myself the PT for the mind. And that's because I am actually a PT and I am also a mindset coach. Why did I become an ambassador? Because I have my own lived experience of being diagnosed with a mental health illness in 2015. I was, a secondary school teacher and resigned from my role, and then set up a community interest company to support, educate and empower primarily Black and brown young women and girls about the benefits and importance of physical and mental health. So that's me in a nutshell.
Thank you so much. So Gareth, why don't you introduce yourself?
Yeah, hey there. I'm Gareth Griffith. I'm a senior research associate here in the University of Bristol in the medical school. My background is in geographical sciences, but I also have lived experience that I dropped. I ended up doing a PhD in mental health, having dropped out of undergrad, being not very well, and then pestering my supervisor to let me do it, which was a big old swing for him. But yeah, I've ended up in an epidemiology department, and I look at how participation and selection and how the forces which affect participation can bias all of our study results, even for the people who do end up turning up to the studies.
Wow, fascinating. And Praveetha, why don't you introduce yourself?
Hi everyone, my name is Praveetha Vitale. I'm a researcher based at University College London. My research is focused on everybody's population mental health, so everybody's mental health, both mental ill health and well-being. And really, so I study inequalities in mental health, development of mental health difficulties through our lives. But really what I'm interested in is what we need to understand the societal forces that shape our mental health and what we need to do in terms of fixing society to help improve all our mental health, both in terms of preventing illness, but also promoting well-being.
Big subjects studying there. Some important questions there. So I wanted to start off with a question for all of you. So feel free to just jump in. Why is it so important that we discuss inequalities when it comes to our mental health, and how can research help with it?
I'll go. So I think for myself personally, when you with research, more people are likely to believe what is being said, rather than, if I say with the statistics that I've read, or if I just came out and said, oh, Black women are more likely to be diagnosed with a common mental health illness, people might just look at me as if being, I'm only saying that because I am a Black woman, but really it is actually true. And there are statistics and research that have proven this. So that's where, for me personally, research really comes in handy, when we shouldn't have to, but prove that point to other people that are not as educated or don't know about the subject, or, would like to find out more information. And it's not, as a Black woman and as someone of color, we don't always want to keep explaining what research can explain in a better way, really and truly. So I feel that that's the benefits of research, and it really cements what's been going on. It gets a wider view of the issue that you're doing the research on. So yeah, that's my point.
Yeah.
Yeah, I guess I more or less entirely agree. I think that part of the change that I've seen in my lifetime of talking about being a bit mental is that is a thing that's much more broadly spoken about now, and it's kind of spoken about in this monolithic way, where we understand that everyone has mental health, and there are things that might help everyone, but there isn't much nuance about who and what within that might end up needing greater attention, although the people who we are aware that there are distressing things that happen in everyday life to everyone, but there are some people who undeniably just go through way more stuff than others, and unpicking those things in the research is what's truly interesting, and what becomes sort of an egalitarian movement, right? It's about equality in those outcomes. It's not just sort of moving everyone up a bit.
Yeah.
And I guess to add, I think that, as you already somebody meant, like, we know we live in a structurally unequal society. And I think sort of evidence that highlights this in all sorts of ways is always helpful for those people who somehow believe the myth that we live in a true meritocracy where there is no longer any structural inequality. But also the other thing that's really important about inequalities to remember is unequal societies are bad for everyone. So there's this general perception that, in an unequal society, it's only the disadvantaged in that society who struggle. Yes, they struggle more, but the unequal society itself is bad for everybody's mental health, it's bad for everybody's health. So I think that's another sort of way in which this type of research that highlights that unequal societies are bad for everybody's health are important, because if it's not intuitive, everybody walks around thinking that's not the case. So I think, yeah, that's sort of multiple roles that research plays in trying to address unequal societies, I guess.
Yeah, great point. So Andrea, I've got some questions for you. Could you maybe talk a little bit about how any inequalities you might have encountered have really shaped your own mental health journey?
So yeah, the inequalities on my mental health journey were at the very beginning, where I didn't actually know what like mental health. Obviously, I know we all have mental health, but in the case of when I went to the doctors and he diagnosed me with mental health, it was a mental health illness. I wouldn't have diagnosed myself with that because, and when I mentioned earlier about lack of education, it wasn't me being rude, because I actually classed myself in that category at the beginning as well. You know, the lack of education around mental health, and from my background, it's something that's not widely spoken about. And so, you know, whereas I know maybe some of my counterparts, they have open and honest conversations about mental health and how it is in society. And then so being diagnosed and being prescribed antidepressants, and again, due to my lack of education, not knowing that I could have actually asked for talking therapy, CBT, something else other than medication. And so I feel like that's what a big part of inequality, because it's not an equal playing field especially when it comes to medication and prescriptions and so on and so forth, you know. And so that's another reason why I'm really big on social prescribing, because again, I didn't know that even existed either. So, and just the inequalities of being a Black woman, and you know, you get the stereotype of if you're not smiling, you're the angry Black woman. And you know, there's so many things that we have to making sure that we're smiling or we're doing this, and that alone is you know, is not great for our mental health. So my journey in terms of inequalities has been, you know, just the whole not knowing about mental health to begin with, mental ill health, shall I say, whilst being prescribed antidepressants, again, knowing that there are other things out there. And so, yeah, it's just been a case of, and then also going to events and not having representation, you know, with the, you know, there's been lots of events I've gone to, and then they're talking about mental health, but they're not talking about all mental health, because you don't have representations on the panel that are able to discuss what it's like from different backgrounds and communities. And I also deliver the mental health first aid training, and that was something that came up. I'm a plenary speaker for Mental Health England as well, and one of the points that a lot of the people that are training would likes me to talk about is my experiences of being a Black woman with a mental health illness, because you know, a lot of the time it is a room full of white people, or you know, people are not Black, and so it's just a case of they don't know what it's like, and so they can only hear what it's like from someone who's actually experienced it. So yeah, sorry for a long answer, but yeah.
No, it is. It's you've touched on it a little bit about the kind of intersectionality of being a woman and being Black, and how that's impacted you. I mean, would you want to talk about any of the kind of experiences that you've had in particular?
I'd also go back as far as saying, like at work. So being a Black woman, I was head of 2 departments in a London secondary school, and people always say, "Didn't you see it coming?" You know, yes, I did, but I didn't want to say anything to anybody, because I was in a position where I thought, you know, this is something I should, you know, I was proud of myself for being there, but if I tell them that I'm feeling this way, maybe because I am Black and I'm a woman, that they're gonna, you know, sack me, or I won't be able to do my job properly, or I'll be demoted from my role. And you know, there was very few people that looked like me that were in those roles, and so I feel like that was a knock-on effect to my, you know, my mental health diagnosis, because I wasn't able to talk about it as much as I know that now when I've spoken to ex-colleagues, that they were experiencing similar issues, but were able to have those free conversations. And then another issue that I faced is being a Black woman, and I'm also a bodybuilder, and so that is something that, you know, you don't really see. And then the negative comments that I would get from people, that wasn't helping my mental health as well. And so it's just a lot that we have to juggle, you know, like I mentioned earlier, we're always trying to put in a smile on your face, because if you're not smiling, you're angry, or if you raise your voice, you know, there's so many things that we have to think about on top of life. It's heartbreaking, and then that's another reason why I do work with Black and brown young women and girls, because I've experienced it, and so I feel like I can be that role model for them, to give them that first-hand experience and to show them that, educate them in that you can speak up, you can ask for different things. There are these things that are available, and really being that person that they can have those conversations with, because it's getting there, but it's still not openly spoken about in the house. So in some house, I wouldn't say all, but in some houses, you know, and it's a generational thing, you know, it's passed down. So we've got to break that cycle of having those conversations, and I teach young people how to have those conversations with their peers and with their families.
That's fantastic. It's great that you're doing that. You're really helping the kind of next generation to level up, I would say, by doing that.
Definitely.
So what do you kind of hope for them then? What do you want to see kind of the future of young Black women and their mental health?
Oh, I would just like young Black women to be able to speak freely about how they really feel, and not feel that they're going to be judged, and not feel like they're going to be penalized for saying how they're feeling, and not having to feel because you're in a particular role that again you're going to be penalized because you feel this way, or because they feel that you think that they may feel that you won't be able to handle the role that you're doing. I think it's just about a lot about communication, and really being able to express ourselves, being able to know, educating them to know that, again, it isn't always about medication. And I know we're talking about Black women, but it's really rife with Black men and boys as well, especially when it comes to in the police departments. You know, they're more than likely, when they're arrested and they're showing any signs of, you know, what police may deem to be mental ill health, that they're sectioned. You know, it's rare that they're, you know, that they're taken to hospital, or normal, like a regular hospital. They're sectioned, and then they're caught up in that system. And I feel, and it's hard, so hard for them to get out of that system. And then we've just had reports about young Black girls being excluded from school. The question that we need to be asking here is that, what happened to you? Not what's wrong with you, what's happening to you? Why are you, you know, having more people to have these conversations with them, to ask them, are they okay? So again, going back to the work that we do at Focus CIC, it's building up young people to become peer mentors, to become well-being champions, ambassadors, to, you know, to that we're saying, to just break that cycle. And so, in answer to your question, what I would like is just for young Black women to have these open conversations and just feel free to be who they want to be, and not have to conform to the way society says that we should be. You know, so yeah, I could go on. I could probably take all the minutes, but I'll stop there.
It's so important what you're saying, and about how it sounds like you really feel like you have to police yourselves quite a lot of the time, and obviously that just has a real impact.
Tiring.
Strain.
It's tiring. Even now, when my mental health is in a good place, it's still tiring to think that, you know, you have to explain yourself, or if you crack a little joke, and I get told off about that a lot from my friends. It's like, no, you don't have to explain yourself. You didn't say anything wrong. But we're so used to being judged and not wanting to make the other person feel like you've done something wrong, when you haven't really. And that's just, again, conforming, and the way how society has made us feel that we should be saying sorry for things that we haven't even done wrong.
Yeah. Well, thank you so much for sharing that.
I'll put myself on mute.
So Gareth, obviously Andrea talks quite a bit about kind of her experience with race and being a woman, but when it comes to research, what is it that we sort of mean when we're talking about inequalities?
Yeah, I think that's a very, very interesting question, and one that I think I'm not sure and I know now that I've come to an epidemiology department. I think in my previous life I worked in a geography department, so I did my PhD on the distribution of mental health, the sort of mental health outcomes in the UK, and how where you lived predicted that, essentially. And one of the things I think it's amazing that it's more on the agenda of research organizations to think critically about inequalities and how we should address inequalities. But I think quite often it isn't like necessarily thought about that much what we mean by it. I think if I were to go and ask if I was going to ask some people in my department what they meant when they said that they were studying inequalities, I think quite often they just be like, well, the outcome's different for different people, and that's what an inequality means. And I think that actually, when you think about an inequality, most of the time what you're talking about is the systemic grouping that you've imposed upon the people that you're seeing, and you're seeing whether there are group differences between people. And there are multiple ways of thinking about that also, you know, whether you care about differences within the group or you care about differences between the groups and that kind of thing. I used to when I was in my old days as a geography lecturer, sans elbow patches now, but I think you have like, if you imagine, so my example for this is if you imagine a chessboard, right? And if you imagine, so I got thinking of a relevant outcome. So say everywhere, the chessboard, the tiles on the chessboard are villages, right? They're villages in the UK. And in the black squares, everyone is depressed, right? And in the white squares, nobody is depressed. If we take that board and we look at the level of the squares, that is an incredibly unequal board, right? There are some places where everybody is depressed and some places where nobody is depressed. But if we just cut the board in 4, it's a completely equal outcome. And so you can have these seemingly contradictory things where there can be very, very high levels of inequality and very, very low levels of inequality, depending on what the grouping is that you're looking at between the groups that you're comparing between. And I think that's something that we need to think pretty critically about in this kind of area, because we're at this stage where it's kind of fledgling, and we get to think about defining the boundaries of what we do, and it's quite an easy thing to come unstuck on if someone is asking you about, so like why should inequalities matter, what do they mean? And I think if you've not got a good answer to that, it's quite easy to be dismissed out of hand.
And so Andrea obviously touched on kind of representation and about seeing Black women, you know, in different positions. And I know that you work in a lot of recruitment when it comes to mental health research. So what are the challenges that you've faced with recruitment for mental health research?
Yeah, I think this is, at the risk of sounding like a huge stats nerd, this is another stats thing that I find interesting in mental health research. I guess partially from my experience of being, you know, like a brownish guy who wasn't very good at talking about having mental health problems at the time. And I think coming into studying mental health, you know, most of the studies we do are on self-rated mental health, right? So it involves you turning up and you telling someone how you're feeling. And I think that actually it's not particularly well recognized that that's quite a big ask of people a lot of the time, especially if people have been structurally disincentivized from going to and talking to people who are in positions of power. If you haven't demonstrated that if you haven't earned the respect of those people, then why should you expect them to come and present to you with this stuff? And I think that actually that's broadly appreciated in the sense that, like, hey, we recruited a bunch of rich white people, and our rich white people results might not generalize outside of this bunch of rich white people, but it's usually assumed that they will hold within the group of rich white people. But it turns out that in lots of instances, even that isn't true. So if you had, for instance, if we take Andrea, for example, and you know that, for instance, it's if you're a woman, or say if you're an ethnic minority, you're less likely to turn up to a study, which we know is the case. If we go and recruit people at random, ethnic minorities will be less likely to turn up. And it's extremely plausible. I think it's pretty plausible, presumably quite obvious, that if you're incredibly depressed, you're less likely to turn up to a study. So if you then think about the people who are left to turn up in the study, you're going to have an overrepresentation of mentally healthy people, and you're going to have an overrepresentation of non-ethnic minorities. And the people who are an ethnic minority who are really sad are never going to turn up. And so the only people you find who are sad are the non-ethnic minorities. And that actually gives you this completely wrong intuition that amongst your group, you should be incentivizing people who are not ethnic minorities. And that's just as a result of the fact that you've not recruited the right people. You've not got the right sample selection in place. And I think that actually the sort of connection between what is this quite arcane selection bias thing and the fact that it is a representation issue at its heart is that you're disservicing everybody who's taking part in your research because you're not recruiting well. I think that's why I became interested in it, because you're clearly conditioning on people wanting or feeling able to turn up. And the idea that you've not done that and we should just ignore it and generalize is kind of mental for me.
It sounds like it's a real challenge to, like you say, be as representative as you can in your research. I mean, do you see any way forward for that? Do you see any solutions to that?
I do, but it's not particularly so. It's kind of my favorite answer for that is that you basically can't solve it with research. I think I work with lots of people who are way smarter than me. I'm pointing up the corridor to where their offices are, way smarter than me, doing loads and loads of really clever math stuff to try and adjust for the fact that we know that we don't get everyone in our study. But all of that relies on this completely untestable thing that we know the reason they didn't turn up. And actually within research, there's actually loads of really good research that could be done on like qualitatively going and engaging the people who didn't turn up, but pretending that you can maths away the fact that you've ignored half your population is not something that you can do entirely viably. And so I think the only thing you can do is engage, is develop trust with people, is engage populations more. I don't think that there's certainly not. I've spent quite a long time reading up on them. There's not particularly there's not one method that fills you with a huge amount of hope for solving that problem.
Yeah. So do you think that kind of all of our problems would be solved by representative recruitment?
No.
No.
I think so. If you imagine, this is also sort of I guess a broader stats point. But if you imagine that we're in the era of big data, right? Everyone loves Amazon or all of this stuff. You can see everything on Google. If you're in the era of big data, you can conceivably, even if we had a conceivable data set, which I don't think we should create because the person who was looking at it would have all the power in the country, right? But even if you had the entire records of everyone who was currently attending the doctor and looked at, and prescriptions on antidepressants or something, even if you had that information, you are still conditioning on people feeling like they can go to the doctor. So even in the instance where we have full representative recruitment, the world that we're modeling is one where we know that people are differentially able to go to the doctor. And so we will find that exact same problem again with recruitment if you think about it as recruitment to the doctor, if we know that there are people who are less likely to turn up to the doctor because they feel like they can't, that will just present as those people being healthier. And so if we look amongst the people who are going to be prescribed, we'll find correctly the people who are currently being prescribed antidepressants, but that won't answer the question that we're interested in, which is what is causing depression. So even if you recruit everyone, you have to think really carefully about the outcome that you want, because you're selecting people even in them turning up to a doctor. Sorry, that was a bit ranty. I apologize. No,
it's fine. It's good to get passionate about it. It's a challenging subject.
And I just add in there as well, because I feel like this is, do you agree, Gareth? This is where the importance of social prescribing then comes into it, because people are more likely to go to someone like a centre or join a club and then maybe feel comfortable in saying to somebody, this is how I'm feeling, if there was someone there that was able to provide that service. Whereas like you're saying, that many people don't want to go to the doctor. I only went to the doctor because my school told me to go to the doctors, so I just thought I was just upset or work overload, burnout or whatever. So yeah, I feel, what do you think about social prescribing in terms of that?
I think social prescribing is a really, really interesting one because it clearly does, as long as there's awareness of it, it clearly does appeal to a different type of person. And it's not just like come in, get binned off with antidepressants immediately. And I feel like yeah, I have the same experience of I got diagnosed with had a 10-year anniversary last year of being on various antidepressants and stuff. But that was a result of me basically coming very, very close to hurting myself really severely, or not. But it's not like a thing that I was like, make the voluntary conscious decision to turn up to a doctor because I'm a rational adult. That isn't, and pretending that the world does work like that really, really does a disservice to all the people who are living these immensely complex and also disserviced lives where they are being structurally oppressed essentially by all these things which stop them being able to do that. It's extremely plausible to me that there are some people in the country who do opt into medical procedures and stuff like that voluntarily and completely rationally, but it feels like comically naive to assume that that's the case for everyone. And I think that to the extent that social prescribing broadens the net that people can have access to that kind of healthcare and feel empowered to go and seek out and have their health seeking behaviors, I think that can only be a good thing.
Yeah. So Praveetha, I want to bring you in it at this point, because I know this is your area of research. So could you maybe tell us a little bit about your work and what your findings have been so far?
Yeah, sure. I just wanted to add or stress on one of the points Gareth made before, which was around trust and sort of societal oppression, discrimination. I think, especially with certain groups, there has been such a history of, even when people seek help, to be mistreated by the system, that to then turn around and say, now trust us and come to us is a big ask. So I think as a sort of mental health research and practice community, I think much more work needs to be done to sort of ensure people are willing and able to come and seek help. And that is not discussed enough, I think. And I just wanted to flag that that's a really good point we should talk about more. So yeah, this is my area of research. And I think, I mean, I can tell you a lot about my work, but I probably shouldn't. But I just wanted to a little bit start with what Gareth said earlier around what do we mean by inequalities. And I think the way I think about them, at least, is so there's going to be variation in mental health in the population, right? There's always going to be some people who struggle with their mental health more than others. And there's always going to be these differences between people. And I guess the problem, or the thing that I don't think, or that I think we're trying to understand, is when that is systematic and systematically biased against some people. So in such a way as to be unfair. And I know fairness is a big concept and philosophers consider and argue about it for a long time. But I think that, to me, that's the essence of what we're trying to get at with inequalities research. So for example, I mainly do research with young people's mental health and adolescents, and I've studied various different dimensions of inequality. So obviously inequalities can be by many things. So whether it's gender or ethnicity or sexuality or disability. So there's like many dimensions by which things can be unequal. But let's just take gender, because it's, well, I was going to say simple, but it's not simple, but you know, it's an example everybody can understand. So if you study just a few mainly white industrialized countries, what you will find in adolescent mental health is that girls have sort of almost twice the level of sort of depressive symptoms and distress than boys. So we did recent work with colleagues looking at data from 78 countries that were not just white and high income about this gender gap in adolescent mental health. And what you find is this is not a universal constant. So it's not sort of some sort of a biological fact that women have to be twice as much distressed as men. There are many countries in the world in which this gap is almost non-existent. So again, really highlighting that certain things that we think are a given when we study certain populations, when you start to widen where you look, you might find things that are not intuitive or surprising to the sort of established research sort of knowledge base. So that's just an example of, I think, sort of one thing I wanted to flag about sort of inequalities in research and where we do research as well. And then obviously the dimensions of inequalities don't, like, you know, people are many things. So, you know, and obviously there's this question of multiplicative or additive effects. So if you are, for example, a sexual minority, ethnic minority, and disabled person, your risk of mental health difficulties might be higher because you are facing many more challenges in society, and society is not, you know, and I think, again, it's much harder to study these things, and sometimes these things are not multiplicative. So the sort of, if you have multiple disadvantages, their effects may not be more than the sum of the parts, but the sum of the parts is already a lot. And I think we often forget that when we think about intersectionality, which I think is just another thing I wanted to flag. And the last thing is inequalities in outcomes. So we've now just been discussing inequalities in who experiences mental health and how they access treatment. But then there's also a question about people with mental health difficulties having unequal outcomes in their lives. So for example, we know that, for example, adolescent mental health poor adolescent mental health is associated with a lifelong of poorer health, earlier mortality, poorer economic participation, poorer social participation. And that doesn't have to be the case. So I think we should also, as we're working towards reducing inequalities, the other inequality to reduce is in outcomes for people with poor mental health, because there are always going to be some people who struggle with their mental health, but as a society, we should be able to support them in ways and, you know, intervene early enough, support enough that their outcomes for the rest of their life are not sort of worse than for young people without mental health problems, for example. So that's another dimension of inequality, I think. So mental health inequality, inequalities by people's mental health status.
Yeah. So not just inequality by kind of your socioeconomic status or your race or your gender, but also by your actual existing mental health conditions. Yeah, fascinating. I could listen to you talking about the difference in, you know, women and men's mental health around the world all day. That, to me, it's fascinating that different countries have different levels of, you know, in gender. It's incredible to me that that can be so different around the world. And yet also, as soon as you say it, it makes sense, I think, as well. One of the questions I had for you was about what kind of challenges you've had when you're researching this subject.
I think Gareth has already outlined the challenges, but I think the fundamental problem is that the data we tend to have tends to be from the most advantaged in societies. And this is true from within societies, but also globally. So when you think about, again, young people's mental health research, because that's what I know best. So although around 90% of adolescents live in low and middle income countries, and that is officially the population distribution in the world, 95% of adolescent mental health research happens in a handful of sort of rich, white, high-income countries. And that's a problem. So again, it's not just for what we know about mental health and generalize to the rest of the population, but just generally, like if most of the people who are going to struggle with their mental health as young people are not in the places where this is being researched, I think that's a big inequity to redress. And then hidden populations. So not only, I mean, there's certain populations that we really are very poor at studying, for example, the homeless, you know, so that I think there's data into these type of big surveys and stuff tends to be biased already, as Gareth has said, but then there's certain populations that, you know, we don't even know we're missing, essentially. So yeah, I think lots of challenges, but that's the most succinct summary I can come up with.
Yeah, and I suppose for those hidden populations, you don't know what you don't know. If you don't have access to data about them, then how do you know you're missing them? So what do you kind of think, what's the future direction? What do you think the future of research in that area is?
That's a very big question.
Yeah.
I don't, I mean, I think I touched upon the global inequality. I think that is something that I hope we'll see more change in the next decade or two. There's also the question, I think, just generally around who decides, for example, who gets to do the research, what research is done, who informs this research, whose voices are heard. And I think in mental health research, that is still a very specific group of people. And I think until we widen both in terms of disciplines, so whether it's, you know, psychiatrists or all other disciplines or the type of people, yes, I think there's a lot that can be done in terms of sort of whose voices, who gets funding, what types of questions are researched, like inequalities research in mental health gets no funding compared to, for example, if you wanted to scan some brains or do some genes analysis. So I think there's sort of many ways in which the future of research could be improved to tackle this more.
So just a question off the top of my head, and Gareth, feel free to jump in. How has your research shown any kind of difference over the last 18 months with the young people that you've been working with, and how COVID has affected people differently depending on their own situation? As a question for Praveetha and Gareth, if either of you have encountered that.
So on this particular question, on young people, don't have a definitive answer. We have a project ongoing, and hopefully, at least in the UK context, we'll have some good answers in a few months. In terms of adults, Gareth and I are just actually finishing a paper using longitudinal data from many British studies to look at this question. And there seems to be an impact on population mental health, again, with all the caveats that we've discussed of who's in these studies and who responds to these surveys. And we do see some signs that the impact might have been larger in women. And it's worth flagging because women already, at least in the UK context, report worse mental health usually than men. Gareth, do you want to add things?
No, I think that summarizes it pretty well. That amongst the people who turn up to these studies, it definitely does seem that females have worse mental health, and that there was a dip which has been reasonably sustained. It didn't bounce. Well, doesn't appear to bounce back in the way that you'd kind of hope that it would. Given narratives of this being like a huge shock with lockdown, there were some groups that it did look like there was an initial widening of gender gaps, sex differentials in the first imposition of lockdown between March and April. But the dip from pre-pandemic levels seems pretty consistent.
I think the other thing to just flag, just because I mentioned this earlier about the impact of the pandemic on people who had pre-existing mental health difficulties. So the other thing we've been looking at is sort of whether people who are already struggling with their mental health when the pandemic started, whether they're sort of not pandemic related necessarily. So sort of things like, because we know because of the pandemic, there've been like millions of NHS procedures that have been delayed or cancelled. There've been people who've lost jobs, been furloughed. And what we find is those with prior mental health difficulties have been more likely to experience these negative impacts of the pandemic. So whether it's, sort of healthcare disruption or sort of losing work or losing income and things like that, which again, just highlights that, we need to support. So the stuff that's been happening to support people is obviously still more disadvantaging those with prior mental health difficulties, which will hypothetically or potentially lead to widening inequalities in outcomes for those with poor mental health, which is something we don't want and should do more to sort of address.
Thank you. So we've got about sort of 20 minutes or so left. So I'd like to move on to some questions that we've had from the people that are watching. So I've got a question here from Louise Strachan, who says, what do you think about intersectionality in the medical model of mental health? A question for anyone. No takers. I imagine it's quite hard to identify people when we're talking about intersectionality.
But also this feels like there should be a question before that about what do you think about the medical model of mental health before we go into so I don't have an answer.
Western medicine's good at like two things, right? It's like the wartime stuff. It's good at antibiotics, it's good at surgery, everything else I can take or leave it, to be honest, including mental health.
Fair enough. So we had a question from Suze, who says, really interesting about selection bias. I am doing research into nature and mental health. As a white woman with lived experience of mental health problems, can you give me a piece of advice to help ensure representation? I'm going to go to nature-based groups to recruit those with lived experience. So do you have any advice on how to recruit people for studies?
Yes, so it's the first time I've ever been able to say this, but I actually have a research paper that I'm about to do on that. That's about to come out. But it's basically so that the green space and mental health thing, which I think that is a question that's been alluded to. The green space and mental health thing is a really, really interesting one because it suffers from the same kind of things that we tend to think of as problems in designs where we're trying to investigate the effect of nature, right? Namely in that, like, broadly richer, happier people tend to live near nature, and it's quite hard to separate out the effects of being in nature or near to nature from all of the things that are associated with being rich people. And so I think a couple of the things that came out of that research. So this was not from, we weren't recruiting into the study. This was from what's called secondary data analysis. So like data that was already there. We went and did stuff with it. One of the things is that you need to actually be pretty specific about, not you individually, but I needed to. I had done the thinking at the time be specific about what you mean by green space and exposure to nature and stuff. It's whether, you know, there was, I remember there was a famous study which we got talked about in my geography undergrad, where it was like, if you're in a hospital window that looks out on green space, you recover quicker and this kind of stuff, right? So is it that you're literally near it? Is it that your proximity to it is close? Is it that you get to go out and wander in it? Is it that, and are your measures of green space, are your measures of nature, are they taking that into account? We did a lot of stuff with because I'm a geography nerd by background, we did a lot of stuff with like land satellites, right? Looking at where green space was, and that's quite good. That's quite useful to be able to derive green space for people. But actually, quite a lot of the time, that isn't functional green space. It's not space that people can get to. It's not like a park or something. It could just be a bunch of trees. It could be the roof of a building that someone's put some grass on. You know, there's lots of things to think about it. And actually, in the selection bit of it, we found that it was the case. We were looking at genetically predicted liability for schizophrenia, which is something I have a whole other argument with. But genetically predicted liabilities for schizophrenia and mental health, and green space. And whether green space predicted that. And it looked like once you took account of the fact that people lived in vastly different areas, and most of the differences you were picking up were from the fact that, like, if you pick me and I live in a leafy bit of Bristol, and you take the person who's next to me, they basically have the same nature exposure as me. And so a load of the things that we were picking up were just actually the fact that people who live near each other were really, really similar for a bunch of reasons. And if we didn't take account of the fact that they all lived in the same place, then it looked like there was this huge effect of nature, or of living near to green stuff. But actually, a lot of the effect that looked like it was associated with living near green stuff was actually just due to living near other people like you, who were in this case richer and more affluent. But so in terms of tips for representativeness in your recruitment, I would say going out and doing that kind of snowball sampling idea, where you go and approach groups which you know have a special interest in it, is a smart way to get into groups that you don't think are represented. I think that's something that we're not very good at in my field. We're very good at thinking about large scale data sets, so we can, you know, numbers in the millions, but we're not very good at thinking about the people who tend to be underrepresented in those things. I think that also probably speaking to the people who, or trying to gauge who's less likely amongst the people who are in your study. So of the people you approach, how is there anything that can you characterize any of the reasons that people didn't turn up, or any of the reasons that people didn't respond to you in whatever way? I feel like once you start thinking in that kind of way, that's the first step to it. I don't think there's a silver bullet answer. Sorry, that was really long.
I'll also take this opportunity to give our MQ Participate platform a little plug here, because we do run a website called Participate, where researchers can post studies and they're recruiting volunteers for, and that is a great way to recruit volunteers to take part from across the UK. So put that little plug in, head of marketing, that's my job. So Gareth, I've got another question for you actually that's come through. So Gareth, your comments about unintended selection bias in mental health research are really thought-provoking. Given that some people who do not want to use services often turn to the voluntary sector, could this be a possible area for recruitment?
Yes, so I think that's a very good point. So I used to do some work with Mind and Time to Change, the big mental health charities at the time. And they had a lot of information on people's access to local counselling services, essentially, and those were split pretty much between like state provision and volunteer provision, and the demographic of people who turned up to each was quite different. I can't remember off the top of my head what it was, but I do remember the selection process being reasonably different, and that actually in some instances where people have been refused from one, they've managed to find volunteer sort of like supplementation for this kind of stuff. And I do think that it wasn't certainly this is a long time ago. This is like 4 years ago, which feels like a long time in 2021. But I feel like in that it definitely stuck with me that there's a very different profile amongst people who took up volunteer services than people who took up sort of the more traditional institutionalized services. And I feel like that is a really useful thing, because you know, in the instance that we don't, like you say, it's very plausible that people don't turn up to either. But in understanding the biases that we have in either one, we can potentially get closer to a more consistent answer of what's going on. Like if in both of those contexts, say a certain demographic group is disserviced more or experiences worse mental health, that's consistent, right? We can at least be like, we're more confident than we would have been in just one of these contexts that group does experience worse mental health.
Praveetha, can I ask you how you go about recruiting people into your studies, or do you use existing data sets?
Mainly use existing data sets. I only collect data when existing data sets don't help answer the question I'm interested in. Yeah, but it's really hard. So we were recently doing a project focusing on ethnic minorities who are also sexual minorities. And recruitment for that study, really, really hard. You really, really, really had to, you know, so I think, yeah, recruitment is not, and again, for good reasons, I think, but again, because we were focusing on a double minority group that is, you know, a fairly small group in Britain, not very visible, I think we had to really be creative in the ways we recruited. Yeah. And
I know you touched earlier about the question of trust, and about how if people have asked a mental health professional or a medical professional for help in the past and been turned away, and, you know, how can we expect them to then accept, to ask them to trust us again, or to trust that medical professional again? Do you think there's the same question mark within research? Do you think that people are untrustworthy of getting involved in medical research?
I suspect so, and I don't think the trust was about like asking for help and not getting help. It's just, it's harder to trust a system that has discriminated against people like you for a very, very long time. So it's not, so even if you don't in first person experience a negative interaction with the system, you know that for decades, people like us have experienced negative interactions with the system, which makes it, it's the same with the police, right? Like there's lots of discussion about trust in the police and I think it's very similar. So the health system has discriminated against ethnic minorities with mental health problems for decades. So then we see that ethnic minorities are less likely in Britain to seek formal help for mental health difficulties. And, you know, many people have done research on this. This is just, we know that sort of the referral routes and the way ethnic minorities access mental health support is just very different, and usually not until it's compulsory. So for example, for young people, until a school or social services or youth justice for like make a child go to camps, very much more likely that way than the sort of voluntary way where you self-refer, your family takes you. And I think, so I didn't mean necessarily based on personal experience, bad experience. I think, you know, so I think it's just living, you know, in a society that has been racist, sexist, homophobic, all of these things for so long. I mean, it still is. So I think as a system, the system has to become more, not just non-racist, but like anti-racist and anti-homo, you know, so and to win people's trust. And that's a long process. Like it can't happen overnight, but I think the system has to do more to do that if they want to serve everybody.
Yeah, for sure. Okay, so I've got a question here from Nicole. So it's quite a long question. So, are you talking about inequalities in accessing help for mental distress, or about inequalities in the human brain between genders and races? Why should research into the mental distress of a human mind be different because of the gender or race of the subject? Isn't the analysis of the findings where the problem lies? If we assume only a certain type of person has problems because they're the only ones turning up to the research, we're assuming that the human mind is different in different types of people. So quite a long question. I think she's asking about the differences. Are we researching the inequalities themselves, or the effects that has on people's minds?
I guess I take a stab at that. I guess it depends on the research question a lot of the time. So if you're interested in something like if you're interested in some like physiological consequence of mental health, or like as Praveetha does loads of work on like long-term life course results of exposures to things, or I guess exposures to mental ill health, I think then in that instance you're thinking about differences between groups. But I feel like my my slight hedge about the phrasing is I think that eventually it comes right around. But I think the inequalities in the human brain bit, the idea that it's in the human brain makes it sound somehow intrinsic and not an imposition of all of the things which are structurally arrayed against you, such that I think a lot of research, usually by like incredibly privileged people, I imagine, has this very, very individualistic focus to it, because in the vein of how research has traditionally been carried out, it's been carried out by people who have an incredible degree of liberty to do whatever they want, and so they kind of assume that other people can do that to some extent. But actually in the knowledge that we have these things imposed on us, and that those things are quite often in common on the grounds of sex or race or ethnicity or these things, that those things are in common. I think you need to start. It implies that there's a this is a total tangent. I apologize. It implies that there's I think you need to start thinking about greater than individual level. And I guess in my experience, when I've had conversations about differences in brains and that kind of stuff, it's usually been sort of couched in this thinking about very, very individualistic determinants. But I think actually, yeah, that's kind of a total straw man, because then you go on to demonstrate that wasn't what you were thinking at all.
Okay. So I've got one final question for all of you then, which I'd like to ask, which is, if we look at the mental health community as a whole, what changes would you like to see in order to address some of the inequalities that there are? Andrea, why don't I pick on you first?
What would I like to see, apart from obviously what I mentioned earlier, but more representation when it comes to medical support as well. Because a lot of the, I can speak from my own example from when I was diagnosed, and I did get from my school the opportunity to speak to somebody, a counsellor, but it was a white male, which I didn't click with him. So it wasn't something I was able to utilize because of that. So if we have the option to, pick who you want to speak to, and I feel like that will make it would have for myself personally a big difference. Again, it comes back to that representation and representation basically within the medical industry.
Okay, great. Gareth, Praveetha, who wants to jump in? Gareth?
Yeah, sure. I think, what do I think mental health community as well? I think that we could do a better job of thinking bigger in terms of the interventions and the changes that we're willing to make to improve people's mental health. I think that quite often, again, coming from a research background, which I am so apologetic that is the only perspective I have to offer at this point, it's so boring. I feel like a lot of researchers, it's extremely telling what they're willing to consider an intervention, right? Like in a statistical model for something, they'll be like, hey, these people took this drug, we'll adjust. Adjusting is trying to get rid of the differences that are due to like ethnicity or due to where you grew up or due to what school you went to. We'll adjust for those, we'll get rid of those differences because they're not important, and we'll look at the effect of this tiny drug. And I think it's extremely telling that you can never think about, doing something structurally to alter where you live, the quality of the housing, those kind of things. Those kind of things could be and should be, in my opinion, thought of as interventions for mental health, rather than as things that we should be ignoring in search of a wonder drug or some gene that explains 0.001% of variation in mental health. That's boring and pointless. I feel like thinking bigger there's a bunch of reasons why I think a lot of the evidence-based literature is kind of stunted in its imagination. I think part of that is that if you do this big evidence-based thing, if you do this big, like we need to evidence things with data and numbers, you are constrained exclusively to things which have already happened, which means they're the only things that you have data on. They're the only things you can evaluate, which means you can never think big. You can never do new positive stuff, which we suspect and we all kind of know would help. Mm-hmm. But it just means that it means that you end up with these very, very niche little minutiae things that you're wiggling in the margins of this thing that we all know isn't working.
Okay. Praveetha, anything to add?
Just to say, I completely agree with everything Andrea and Gareth have said, and I've already ranted about representation in research and in our data. So nothing to add on this, but I think all of those things are super important, and lots of people talk about it. but change doesn't really happen, or it's not happening quickly enough. I was a teenager and I thought, yeah, you know, by the time, you know, the society has been sort of sexist and racist for so long, surely it's all fixed. I'm an adult now and I know better. Not fixed, not even close. So I think, yeah, I think doing more to make society more anti-sexist, anti-racist, anti-homophobic, all the things that we know drive inequalities would be, as Gareth said, big solutions instead of tinkering at the edges. And I think also individual responsibility versus societal. So lots of the solutions we have to mental health problems these days tend to be about, I mean, it's not the best term, but fixing the person. Mm-hmm. So for example, just thinking about young people's mental health, lots of interventions around teaching young people how to problem solve, teaching young people how to regulate their emotions, but nothing about reducing sexual harassment that young people face, or, you know, making society sort of less, sort of reducing the meritocratic myth, so all children don't feel stressed that they have to do well in school because that's the only way to have a decent life. You know, having a social benefit system that means most people can live a good life with, you know, so all of these like things. So the solutions seem to be all about fixing individual people rather than fixing society. Mm-hmm. And I think we need to do more to fix society.
Yeah. Big problems. Okay, well that's it. That's all we've got time for this evening, I'm afraid. So thank you so much for everyone who joined us for coming today, and I want to say a massive thank you to all of our guests as well for joining and for having this really fascinating discussion. So thank you very much. So for anyone who's watching, where can they find all of you on socials or your websites? Andrea, where can people follow you?
Thank you. So people can follow me we're mainly on Instagram, so focus.cic, and we do actually have a website, so www.focuscic.org, sorry, and mine is Andrea Corbett. Yeah, Andrea Corbett. So yeah, Focus CIC and Andrea Corbett. So the work that I do with young people is on Focus CIC. So yeah.
Fab, thanks. Gareth, if people want to follow you, where can they find you?
Yeah, I'm extremely inventive and have the Twitter handle Gareth J Griffith, all one word. Just like my name. I apologise for not being cooler.
And Praveetha, where can people find you if they want to follow you?
I'm similar, but my name is very long, so it's just Prav Patalay instead of Praveetha Vitale, but I can put it in the chat if that's easier.
Okay, perfect. Well, I want to say a big thank you again to all of you for joining me, and thank you so much for giving up your evening, and thank you for everyone who was watching as well. Also, I want to say a big thank you to everyone who donated for their tickets. Obviously, MQ is a charity, and we do rely on the generosity of the public to help us fund the research we support, which is going to help find the next breakthrough in mental health. If any of you who've been watching and have enjoyed this evening would like to make a donation, please head over to our website, which is mqmentalhealth.org, and you can also find out more information about all the different research projects we support there. So thank you very much, everyone. I will let you enjoy the rest of your evening, and hope to see you again soon at the next webinar. Thank you.
Thanks very much, everyone.
Thank you.